Hello everyone, welcome to this session on acute coronary syndromes ST-, probably one of the most complex, heterogeneous and diagnostically rich entities of ischemic heart disease. So I'm not going to introduce you to the members of the GRCI, whom you know by heart, whom you've been working with for at least 48 hours. Instead, I'd like to introduce the prestigious guests we've invited to take part in this session with Johan Sylvain from La Pitié. We have Ziad Bouhari, who is now in Marseille. We have Thomas Cuisset, who is also in Marseille. Frédéric Buisset is in Toulouse. And we have a prestigious guest who we don't need to introduce, but it's a pleasure to do so anyway. Patrick Series, one of the leading figures in cardiology and interventional cardiology. So what's this session all about? It's a PCR session. So it's been 4 years since we initiated this at GRCI in partnership with the PCR, who gave us a lot of shape with Jacques. We've worked a lot with them, and this notion of a common thread with a clinical case that will enable us to visit all the complexities of non-ST-ACS ischemic cardiopathy without further delay. Well, let's get started, Jacques.
Here we go. Thank you, Hakim. So this session will be based on a clinical case, as Hakim said, with the first part, which will be the initial management in the form of a PowerPoint presentation, and a second part where we'll actually go on to revascularize this patient via a LIAB. So our patient today is 77 years old. As you can see, he's frail because he's 1.64 mm tall and weighs just 44 kilo with a low BMI. This will be important in the analysis of our patient. This is a patient whose risk factors include familial coronary artery disease and high blood pressure, who is a retired active farmer, and who presents with a fairly typical inaugural chest pain at 4 a.m., for which there will be a delay in treatment, because he's one of those people who come from the heart of the Alps. They're very tough. They only come when things really aren't going well. And unfortunately, he won't call 15, but will go straight to the emergency department. When he arrives, he's always in pain. His hemodynamics are stable. He has this electrocardiogram, which isn't very pretty, you'll admit. I don't have a referent electrode because there's this big left bundle branch block, a supra or ventricular triplet, and yet hemodynamics are preserved. The first echo shows left ventricular dysfunction with a dyskinesia fringe that is probably related to the left block, but above all there is enterolateral hypokinesia, and the first troponin is 45,000, so already very high. Creatinine clearance is 51, which means moderate impairment of left ventricular function, and there's a slight anemia. And here's his coronary angiogram, which is done immediately afterwards. The patient has a normal right coronary artery. On the epicranial view, you can see a very tight lesion on the diagonal, which I'm going to call the culprit lesion, given the importance of the territory of this large diagonal branch, and then an associated lesion on the proximal IVA covering the ostium of this diagonal, as well as a lesion on the middle IVA, a slightly long lesion. We therefore decided to heparinize this patient with 70 kilo units. We decided on a revascularization strategy. I'm sorry, he's already been given aspirin in the ICU, and on the table I give him 60 milligrams of prasugrel. Why prasugrel? Because the patient has no teeth. So I can't give him ticagrelor, which was still my first initiative. He has no teeth, he can't chew ticagrelor, and I decide to revascularize on this diagonal.
So we're going to ask the panel's opinion about this first drug treatment. And I'll ask Johanna, what about giving prasugrel like this for a non-ST+? What do the recommendations tell us?
So clearly, I'm going to show you in the topo right after. But regardless of the recommendations, my strategy is simple. There's no pretreatment without seeing the coronary anatomy in an NSTEMI. So it's very simple. You don't give anything. You look first, choose the strategy, and give. After that, it's quite simple on the data, and I'll show them to you. So there are exceptions. I'll start with that. But if you stay within the NSTEMI, the NSTE-ACS, the data are pretty clear. And after that, we can make the choice of molecules, and we'll discuss that. So I'll move on to the question. What is the preload in NSTEMI? Teaching studies. So what's the point? I've already given you my answer. There's no pretreatment in the NSTEMI in my department. Why is that? Because even though we were great advocates of the loading dose of preloading in elective angioplasty, we did randomized studies that showed the opposite of what we thought. So sometimes you have to balance belief with science. And why don't systematic studies work? It's because the NSTEACS, the NSTEMI, is a heterogeneous group of patients. And so the benefit of pretreatment can't work in everyone. Why not? Because if you take all the patients with NSTEACS or NSTEMI from the major American or Canadian registries, there are people who won't have angiography or angioplasty who have been treated medically for reasons of fragility or context. So that's 35% of people, and 20% of people who will have an angiography, but who won't have an angioplasty because they're small lesions, so they won't have a stent. There are people who will go on to bypass surgery, 10%, and there are 35% of people who will go on to angioplasty. So finding a strategy with a drug that will give the same benefit for all these different strategies is not possible. So you have to decide on your strategy first. And when you take only the people who have had the invasive angiogenesis strategy, the figures rise to about half for angioplasty. So it's heterogeneous, it's not STEMI. STEMI is very simple, it's very heterogeneous, and STEMI is very heterogeneous. As a result, we can't use the same strategy. Afterwards, we carried out randomized studies. We analyzed all the meta-analyzed studies. It was a meta-analysis by Anne Bellarmine, which appeared in JAMA when she was with us. And so, pre-treated with clopidogrel at a time when we only had clopidogrel in practice, there was no benefit. In STEMI, yes, in NSTEMI, there was no benefit. And there were signs of increased bleeding. We did a randomized study with the ACTION group, which was the only pre-treatment study in NSTEMI called ACOST, with 3,500 patients, and we believed in it like crazy. There were 3,500 patients, and we really believed in it. And it was NSTEMI 3 times troponin. We're pretty sure that it's NSTEMI. We're pretty sure that it's going to be stented. And we thought that pre-treatment would prevent it from turning into an infarction. In fact, they don't turn into infarctions when they're in intensive care, or at least they don't turn into infarctions anymore. So there's no benefit to pre-treatment on a very, very broad criterion. Again, a very broad primary endpoint. There's no benefit to pre-treatment with prasugrel versus giving the drug once you've seen the anatomy. On the other hand, as you know from this study, there was a doubling of major bleeding. So there's clearly a strategy that's harmful. So we don't pre-treat with prasugrel. No benefit from pre-treatment with clopidogrel. If you combine 2 data, we saw this in the BMJ, it was a meta-analysis of randomized data. No benefit on death, no benefit on MACE. A very strong trend towards increased bleeding. So overall, no benefit, but beware of a safety signal. If you take ticagrelor, which is in a class of its own because it didn't do a pre-treatment study, it was for everyone, whatever the strategy. There is, however, the subgroup of 11,000 NSTEACS patients, i.e. NSTEMI, half of whom were treated medically, the other half with angioplasty. And if you take this study, which is more of a long-term study, a bit old, we have a death, a decrease in events, but it's not immediately, it's progressively. At the cost of an increase in bleeding, with a signal in mortality, overall, ticagrelor is probably far from a pre-treatment strategy with it. This is one of the few studies that can't give an exact answer to this question. We were asked about the timing of pre-treatment in a race. We were told it's because you give pre-treatment too early or too late, so we looked at the quartiles of 4,000 patients. We published this in the JAC, and overall, not only was there no benefit, whatever the timing you gave on table just before seeing the coronary anatomies or 12 hours before, there was no benefit. And in fact, the signal was rather against pre-treatment when patients were treated directly before angioplasty. If you compare 2 molecules, prasugrel and ticagrelor, there's a very fine German study, the ISAR React 5, which was STEMI and NSTEMI, which overall gave a big advantage to prasugrel. And there was a there's a subgroup NSTEMI, where prasugrel is given once the coronary anatomy has been seen, which overall gives the same message. Prasugrel does better once you've adopted a strategy where you wait to see the coronary anatomy. So the debate on drugs is basically no pre-treatment, rather prasugrel. But there's another way of looking at it, and that's that you're doing a strategy where you're going to see coronary anatomy quickly. And so there are studies where overall you go faster and faster to the cath lab. And so it's a simple way of leaving the patient without a strategy and quickly deciding on treatment. There's this very nice randomized study by Gilles Lemel, published in JACC Intervention, which shows you that overall, if you have a rapid strategy for cath lab NSTEMI, well, overall you have a better prognosis and therefore you can quickly choose things. So that's our strategy, and my conclusion is that's what we do. In other words, for me, NST-ACS means aspirating anticoagulation. If you have a fast-track cath lab strategy, all the better. If you don't, then these are the rare cases where you can do pre-treatment. But in this case, the treatment is similar to the medical treatment of ACS. In other words, you can't have a coro for 5, 6, or 7 days for reason X or Y in your circuit. At that point, you look at your patient, don't leave him with nothing, just aspirin. So clopidogrel, why not ticagrelor if it's a low bleeding risk, while waiting to have an angiography. So all this is a possible strategy. And if you can do the coronography, that's the easiest. You do the coronography, you do the strategy, and if the patient needs to be dilated, prasugrel instead, if you can. Ticagrelor is very acceptable, and the urodispersible form is very practical. And then, like that, you can choose your strategy. You don't have a problem with the surgeon who's going to do the bypass. It's medico-legal in the United States. It's 5 to 7 days off work before bypass surgery. So my strategy is very simple.
Very well, thank you very much. And so, if I put myself in Jacques' shoes, I put myself in the shoes of the emergency doctor who calls you. Johan, I follow me, he's suffering. He has 45,000 troponins. His electrocardiogram isn't looking too good. You resist the temptation.
Patients, it's all the patients we put in Arcost, it was all the same.
So in the end, we can say that Jacques' strategy is the right one for rapid transfer to the cath lab. Loading dose adapted to the patient's dentition. That's for another day, but in any case, 60 milligrams of prasugrel on the coronography table, in the light of the graph, seems to you a strategy that is validated and robust by science.
Exactly. To respond to this strategy, even if we predicted which patients would have a stent, we did a coast PCI, i.e. the 65% of patients who had angioplasty, there was still no benefit, and there was still the risk of bleeding. So we might as well wait, do the angiography quickly, and give the tabletop drugs, which work very well and quickly.
Very well then, Jacques. We're perfectly in line with the science. Now let's get back to practice. What did you do?
So indeed, after giving this prasu preload, I predilated the lesion and implanted a 3.0 stent by 20 millimeters. I implanted a Supreme HT stent from the Sinomed company. I don't think many people in the room are familiar with this stent, so I'll just give you a quick summary. It's a sirolimus stent, a chromium cobalt stent, fine mesh, 80 or 90 microns depending on the platform. There are two types of platform depending on the size and diameter of the stent. So either there are 8 crests or 10 crests with 3 links, which gives it considerable flexibility. It's mounted on a semi-compliant balloon. It's important to bear this semi-compliance in mind, and it has a very special feature. It's a stent with a biodegradable polymer, but this polymer is deposited in 2 layers. There's a very, very thin layer, which is in contact with the chromium cobalt, is 100 to 200 nanometers. It's extremely thin, so it's polyimbutyl metacrylate. You're not asking me exactly what it is, but it does have the specificity of being electrografted. We'll explain a little later, in the form of a video, what electrografting is. It's a unique process because it's a French technique developed by Christophe Bureau, who's here in the room and who developed it at the CEA in Grenoble. So it really is a real French innovation. I met Christophe when he was being treated for coronary artery disease under medical confidentiality. And indeed, he told me a little about his sources and this principle of electrografting, of this very, very thin layer, stimulates re-endothelialization after sirolimus release. And of course, on top, there's PLGA, which is the classic polymeric layer that will be degraded fairly rapidly. And so this confers a very, very important specificity, since it will enable the drug to be released very, very quickly compared with the more conventional stents, whether Science or Resolute, with an arterial concentration that peaks very early compared with the others, and with a much faster degradation of this polymer than the other stents we have the opportunity to have. So we wanted to interview Christophe, and to do so, we're going to send you the video.
Hello everyone, and welcome to this special interview with Interventional Cardiology. Today we're in the CEA Center Grenoble showroom, and we're specifically in the Health Corner. I'm here with Christophe Bureau. Hello Christophe.
Hello.
You have a PhD in physics. You're CEO of the startup AlchiMedics. You're a former CEA engineer from the Fundamental Research Department at the Paris-Saclay Center, and you're the inventor of a revolutionary technology for coronary stents. Could you tell us about the HT Supreme stent?
With great pleasure. The HT Supreme stent is a sirolimus-eluting active stent which derives its very special properties from a bilayer coating developed at the CEA.
And what makes this coating so innovative?
This stent derives its innovation from a technology called electrografting, which makes it possible to manufacture extremely thin polymer brushes around 150 nanometers thick, which are covalently bonded to the metal surface of the stent. This small brush acts as a Velcro fastener for a reservoir around 5 to 7 microns thick, which contains the sirolimus that can be released over a set period of time.
And how does this system impact drug release?
Our aim was to limit, as far as possible, the exposure of arterial tissues to the drug sirolimus. Sirolimus is an anti-proliferative drug which obviously prevents the proliferation of smooth muscle cells that cause neointimal hyperplasia and rostenosis. But it's also a molecule that is very good at inhibiting the migration of endothelial cells, which we want to see migrate in order to heal the artery. We therefore chose to synchronize the sirolimus drug release peak exactly with the smooth muscle cell proliferation peak, and then to make the drug disappear as quickly as possible by choosing a biodegradable release matrix. The sirolimus disappeared completely after 30 days, and the biodegradable polymer matrix itself disappeared completely after 60 days.
This is a very rapid release profile. In concrete terms, what are the expected benefits for patients?
You're quite right. It's the fastest profile on the market, the shortest in terms of release. The advantage is twofold. The first is that it allows you to contaminate the surrounding tissue for as short a time as possible with a drug that we know delays and inhibits healing. And once the biodegradable layer has completely disappeared, the electrografted layer underneath acts as a healing gas pedal, speeding up the migration of endothelial cells. We have been able to demonstrate this through in vitro studies. It accelerates healing by about a factor of 2 compared with a bare metal stent, which is generally considered to be the positive benchmark for rapid healing.
Are these results clinically confirmed?
500,000 patients have now been implanted with the HT Supreme stent. 2 clinical trials have been carried out. The Pioneer 3 study, a randomized trial involving 1,600 patients simultaneously in the USA, Europe, and Japan with dual anti-aggregation therapy, reduced to 6 months, showed extremely low thrombosis rates. A post-marketing study called Pioneer 4 is currently underway in Europe. It involves 2,500 patients. It is also a randomized study, this time involving the use of dual anti-aggregation therapy for just 1 month, made possible precisely because of the ultra-rapid healing achieved with the HT Supreme stent.
So this stent could be particularly beneficial for certain patients.
You're absolutely right. For this category of patients, known as those at high risk of bleeding and for whom long anti-aggregation dual therapy poses a problem, the early healing achieved with the HT Supreme stent precisely reduces the need for these long anti-aggregation dual therapies. More generally, all patients will benefit from this rapid healing.
Thank you very much.
Thank you very much.
It's absolutely fascinating. It's also a source of pride to see the fruit of French research. We can take advantage of Christopher Bureau's presence in the 5th row. If there are any burning questions about electrografting in the audience. Personally, I'd like to know, Jacques showed us that it was adapted to a cobalt chrome platform. Is the principle applicable to all platforms?
So yes, electrograph technology requires the platform to be conductive or semiconductive. So as soon as you resonate on a metal stent, even if it's a nitinol stent, it will work perfectly. As soon as we're working on insulating matrices, on the other hand, electrografting won't work, but it's perfectly feasible.
Electrografting is performed on the entire surface of the stent or on the abluminal portion. This is something that can be modulated.
It's an electrochemical process. So we electrically connect the stent and immerse it in a bath, which is a rather special organic bath. We then apply an electrical voltage to the stent, which causes the polymer brush to grow like hair, except that the brush will be between 1 and 200 nanometers in size, depending on the operating conditions. So it's a technology that works extremely well on complex shapes and will be the same everywhere. The result is a perfectly homogeneous deposit, whatever the complexity of the shape.
So bravo, thank you very much. For me personally, it's a discovery. Jacques, what is your experience with the HT Supreme stent?
Well, I've been working with it for almost a year now, and so far the feedback has been very positive. So with the limitations, it's monocentric, and that's just my experience. But the stent itself is a very nice platform. As you'll see, it adapts perfectly to bifurcations. It's a stent that's really all comers and will pass just about any difficult situation. And it's true that for me, it's a high-performance platform. It's a sirolimus coating. I attach great importance to the drug. This rapid re-endothelialization in this patient, as I showed you, is a patient at high risk of bleeding. He's over 70. He has mild renal failure. He has a slight anemia, but he also has complex lesions. He is bitroncular. As we'll see later on, there is a bifurcation lesion. You'll see that the middle VIA lesion is also a complex one. And so we find ourselves with a patient who is also at high risk of ischemia. For all these reasons, I chose this stent. In the near future, we're going to set up a French registry with Christophe and Gilles Baron in Grenoble called Dior. We're going to include patients with all-comers HBR, and we're going to follow up these patients in the short and medium term. Excuse me?
Thank you very much, Jacques, for sharing your experience with us. But experience is one thing and science is another. And it's important to have robust science. So, I'm going to ask our scientific referent, Professor Serruys, to tell us if there are any platforms, if there are any strategies for these patients at high risk of bleeding. And the floor is yours.
Thank you. So I think the first slide is from the control room.
You press, it goes on to the next.
Okay, so backwards. Should a stent be preferred in patients at high risk of bleeding? That's the summary of the points I want to cover this evening. The first is the balance between bleeding and ischemia. So you see that a post-PCI myocardial infarction increases the risk of mortality by a factor of 5. But in many cases, bleeding is equal to the prognostic value of an infarction. If you look at the second panel, it's clear that a BARC3 gives you an equal value of bleeding and myocardium in terms of prognosis. And if you take a BARC3-5, you see that early bleeding is even worse than myocardial infarction. So it's clear that there's a vulnerable period, not only for the stent, but also for other destabilized plaques and for other peripheral territories, the brain or the peripheral circulation. And the bleeding is there in the first 3 months, but is prolonged if you prolong double antiplatelet therapy. How to identify patients at high risk of bleeding versus those at high risk of ischemia. At study or in practice, you see that we have 5 or 6 scores for bleeding and as many scores for ischemia. Clearly, the dream is to combine the two and eventually ask artificial intelligence to help us achieve the correct prognosis of the patient. So here you see a 76-year-old lady, non-stelamic, diabetic 2, no insulin, hemoglobin a little low, reduced glomerular filtration, 1 right coronary intervention, no history of bleeding, no history of surgery, perivascular disease, cardiac decompensation, atrial fibrillation, and no cancerous disease, but a very severe common trunk, very close to the bifurcation. So if you question all these scores, you'll find many percentages at risk of bleeding, at risk of ischemia. You need to know the score you like, the score you trust, although we'd like to combine all these scores. The second point is that you need to select the instrument you're going to use, and the third is that you need to make a strategy. In this case, what we ended up with was 3 stents implanted with DK crush. Bleeding and ischemia perspective, the validation using ArcHBR risk score. You'll recall that in JAMA, Philippe Urbain, Marie-Claude Maurice, and Stuart Pocock presented this score on the vertical axis. You have myocardial infarction and stent thrombosis. On the horizontal axis, you have BARC3 and BARC-Phe. You can see that patient number 1 has a preponderance for ischemia, and patient number 2 has a preponderance for bleeding. There are 2 formulas in the paper to help you select or predict a patient's future, either preponderance for bleeding or preponderance for ischemia. This is something we applied prospectively in the Pioneer 3 prospectively. The dots in red are patients with a BARC3 or 5 bleed. "17 patients, a point 81, and what was expected was 2.09. You see the myocardial infarction, the yellow dots, 22 patients, 2.34%. And it was predicted in this population, 2.53. 1 patient combines or myocardial infarction, stent thrombosis, and bleeding, and a patient who only has thrombosis but no myocardial infarction. Well, you can see that it comes from all these 929 patients, and you can query the database and see which are BARC3, which are myocardial infarction, which are BARC3. You come back to the total population and you can systematically query the database for the myocardial infarctions that are here. And finally, the 2 cases of thrombosis, one combined with BARC and one isolated. It's a pragmatic approach that we like. The final point is a double antiplatelet therapy, short, 1 month only. That's what we've done in Pioneer 4, but we have the Pioneer 3 comparison. Let me remind you of the work done by Renu Vermani. She uses Evans blue dye, and you can see on the left of the screen, from top to bottom, the healing stent. A bare stent without elution, and at the bottom of the image, you have the Ziens. You can see that the Ziens is much more blue than the Supreme or bare stent. The reason is that the permeability of the connections between the endothelial cells is poor. If you look at the panel on the right, you see histology and histoimmunology. You see that at the top. Healing is a complex covering and complete. A bare metal stents too, but Ziens at 90 days, 3 months, still has struts not covered by tissue. In general, with OCT, you can tell the difference between uncovered and covered struts. We've done this in the Pioneer 2. And this slide shows that at 30 days, the strut coating coverage was 84% for the HT Supreme stent and only 73% for the Ziens stent. We've compared, and it's an approach that's far from finished, we've compared Pioneer 3 and Pioneer 4. For Pioneer 3, you have 6 months and 12 months of DAPT, double antiplatelet therapy, and for Pioneer 4, only 1 month of both, and then ticagrelor only. I would remind you that the Pioneer 4 study is a treatment versus guidance by QFR. And this is my last slide. On the left, the curve of major adverse cardiac events with a landmark analysis at 30 days. There is a statistical point value of 0.25 between ischemic events, 3.6 in Pioneer 3 and 1.8 in Pioneer 4. The reasons are still somewhat obscure, but the point that is important is that we discontinue aspirin in Pioneer 4, and we don't see an excess of ischemic events, since at 6 months, the figures are 2.3 for Pioneer 4 and 1.4 for Pioneer 4. And in terms of bleeding, we don't see any significant difference between the two. My preliminary conclusions are that the impact of bleeding is as great as the impact of a myocardial infarction. Early bleeding is worse than MI after PCI. There are different bleeding and ischemia scores with quantitative prognostic predictions, but we need to harmonize all these scores because the clinician is somewhat confused by the variety of prognostic percentage values. Prospective application of the European PCI Society's successful implantation score demonstrates the success of 98.5% of the HT Supreme stent. I didn't show this data today, but it's comparable to other contemporary stents. And finally, the application of the prognostic model of ARC, HBR combining bleeding and ischemia reveals that the bleeding of 1.81% at 600 days in the Pioneer 4 study is less than the bleeding predicted by the score. That's it.
Thank you. Thank you very much, Patrick, for that very fine presentation. Any questions from the floor or the panel? Any comments? We'll move on to the rest of the case study. If you'd like to show us what you did next.
Well, at 10 days, the evolution was favorable, with the patient not suffering again. Overwatering was down, renal failure remained unchanged with clearance still at 50, and hemoglobin was unchanged with a digestive checkup. That's why we took the time to step back and make sure there was no digestive bleeding before deciding to go ahead with revascularization. An electrocardiogram which still shows a left block, but which is a little less ugly than the one we had initially. Partial recovery of the ejection fraction with, in any case, a normalized lateral wall. This patient also has a small aortic insufficiency. We optimized his treatment classically, and I switched from prasugrel to ticagrelor, given the patient's low BMI. This seemed to me to be something important. So to summarize, this is a 77-year-old man who presented with NSTEMI with bitruncular lesions, a culprit on the diagonal, and then this middle proximal IVA lesion. We decided to revascularize this IVA lesion in a complementary fashion. Here's the angio on day 10. So there you have it.
Jacques, you're off to revascularize. Maybe we'll ask the whole audience who would go for complete revascularization on this patient. So who wouldn't go for complete revascularization in this patient? I think that's very clear. So now that we've all endorsed revascularization, what's your strategy for revascularization in this patient?
So this second part will be in the form of a LIAB. So we've decided to guide revascularization based on plaque physiology and morphology, because you'll see that on the middle IVA, we're going to have a few surprises. We're going to prepare this plaque optimally, and we've given ourselves the means to optimize this management. And then the last part was to discuss a little about this proximal diagonal IVA bifurcation lesion, our attitude. So the setup was 6F right radial slenders, a 3.5 guide catheter, an FFR guide, and IVUS type endovascular imaging, given the patient's renal insufficiency. And if we can send the first part of the LIAB, please. We said we did the FFR. So to tell the truth, we passed the guide after equalizing, of course, in the very proximal part of the trunk, and we have a pressure gradient since the difference is 0.77. We therefore decided not to inject crenosin, given the positive basal state. So now we're going to move on to the second stage, which is evaluation by IVUS. So we've just run the little Boston Cross HD, which passed quite easily.
We have a very good profile.
Very good profile.
Is the OptiCross 3 French HD, the new generation with the new console and new image processing software.
So we've just done the first IVUS run. I'll let Mohammed describe the lesion. Go ahead, Charlene.
As you know, we performed endocoronary imaging to specify the characteristics of the plaque and, of course, to take measurements. What we see is a very atheromatous calcified VIA with stenosis in the middle to distal part, confirmed here on the middle third of the anterior interventricular. We're looking at a septal and then a diagonal. In a moment, we'll stop on a lesion that is highly calcified, circumferential with a 360-degree arc, with a lumen, with an MLA of 2 square millimeters. We're starting to see severe massive calcification. We continue to ascend towards the proximal anterior interventricular. We have a tight calcified stenosis, greatly underestimated on angiography. On the proximal part outside the ostium, the lesion is not significant, but the closer we get to the common trunk, the more we again see a calcified tight stenosis with an arched plaque 120 degrees from the ostium of the anterior interventricular, which extends onto the distal common trunk. We can take a break. We have endocoronary image criteria in favor of lesion preparation according to Zhang's criteria, which were reiterated in the latest European consensus. We have 3 out of 4 criteria. The first criterion is that the artery is less than 3.5 millimeters long. The second criterion is a calcareous arc of 360 degrees. The third criterion is a lesion of more than 5 millimeters with an arc of more than 270 degrees. We don't have a calcareous nodule, but we have enough evidence in our favor to say that to treat this lesion of the middle IVA, we'll do a preparation. Jacques and I discussed this a little. We decided to go for a very fragile patient, for whom we feared a long procedure with a risk of slow flow, no reflow. So preparation by intracoronary lithotripsy. As for the ostial anterior interventricular lesion, we don't have the arguments to prepare this lesion. We don't have the criteria. And angiographically, it's confirmed by endocoronary imaging. So we're going to use ultrasound to prepare the lesion at the level of the middle IVA, implant a stent, and then carry out conventional treatment of a circumflex common trunk IVA bifurcation. As far as our installation is concerned, we have a diagonal guide. I must have made a slight error earlier. It's obviously a lesion of the proximal anterior interventricular at the bifurcation of the diagonal and not the common trunk. There is, however, a fairly high birth of the circumflex.
So Jacques, with Mohammed, you decided to guide this revascularization of a long complex IVA lesion with endocoronary imaging. Could you ask the panel if you would have used the same technique?
Jan?
I think I would have used the same technique. Clearly a fairly elderly patient, poor LV, renal function. It must be a little limiting. I would have done more IVAs than OCT. I think on a very long lesion like that, there are several criteria of complexity that push us to use imaging. We have a long lesion. We have a little calcium on the angioma. We have a bifurcation. That's probably 3 criteria that qualify the lesion as a complex lesion that deserves imaging.
And once again, the angio was at fault in relation to the classifications, which I reviewed after the film a little carefully. Yes, there were some classifications, but when you see the calcareous ring that exists on the middle VIA...
Would there have been different attitudes in the audience? I see Gregoire.
No, it's to stimulate a little interactivity. Don't hesitate.
So in this case, we saw all the interest, all the added value of imagery. At the start of the afternoon, we also saw the value of physiology. Patrick may have had a comment, sorry.
Yes, well, what helps us more and more is the combination of imaging and functional information. So there's IVUS FFR, there's OCT FFR. I really like it because you can actually see anatomy and at the same time where the OFR drop is, and in this case, limit in some way the length of the stent in terms of length so as not to put too much metal in this coronary. The second point is that, well, there's this almost complete arch at a certain point, but I think it eventually merits in first place a non-compliant balloon, and if there's residual stenosis in the balloon, go to more complex technologies given the fragility of this patient.
I'd just like to clarify one point about plate preparation. As you know, I'm a great advocate of shockwave. But it's important to remember, since this is science, we don't currently have any direct comparative data, which would mean that lithotripsy, which is certainly a safe element, is less safe than rotablator. It's a feeling we have. But as there hasn't been currently any head-to-head that says one is more dangerous than the other, we shouldn't bury atherectomy strategies either. on the other hand, I completely agree with you, is the impression that there's a 30% ejection fraction and that we want to be as safe as possible. But if we have to go back to the science, currently, there is no strategy for modulating the plaque that is safer than the other. Despite the fact that, as you know, I'm a great advocate of lithotripsy.
This is where we come to the technical aspect of preparation. As far as assessment is concerned, you've opted for morphological analysis. This raises a number of questions. We talked about this at the beginning of the afternoon. The place of physiological analysis. We could ask Frédéric Buisset to give us the state of the art in physiological assessment of these multitruncular patients.
Thank you very much, Pascal, and thank you to the GRCI and the organizing committee for inviting us to discuss the criteria to be used to select non-culpable lesions for revascularization in non-STEMI. So in non-STEMI, even more than in STEMI, there are many patients with associated lesions. More than 1 in 2 will have lesions on vessels not responsible for the acute coronary syndrome. We could say, it's okay, we've treated the infarction, and for the non-culprit lesions, we'll reason as we would for a stable patient. But that doesn't work, because we've known for some time that, in fact, when we look at what's going on in these lesions, even though they're not culprit, and when we compare these acute coronary syndrome patients with stable patients, you see that there are far more signs of rupture. Some authors have spoken of pancoronaritis in these patients, even in non-culprit lesions. These non-culprit lesions seem to be more vulnerable, so it's legitimate to worry about their management. What's more, we know that in the year following an acute coronary syndrome, there are more events. So it's a subject. It's a subject that the cardiology community has seized upon. Just look at the number of studies that have been reported over the last 12 years on the subject of non-culpable lesions. You're familiar with all these studies. They're all blockbusters, almost all New England, and very important studies that have influenced our practices. But tonight's question is about non-ischemic lesions. And the question is a non-culprit of a non-STEMI the same as a non-culprit of a STEMI? Perhaps not, if we are to believe this Korean study which compared the OCT characteristics of non-STEMI and non-STEMI lesions. It would seem that the non-STEMI may be a little less vulnerable. So if we go back to the available literature and look at the patients in the cast of these studies, you can see that things are going to get a little more complicated, because most of these studies are concerned with STEMI, and only the most recent studies included a certain number of their patients as non-STEMI patients. So when we delve into this literature to answer this question, we're going to have to focus on these trials. What are the questions? Is it beneficial to complete revascularization? What are the criteria for completing revascularization? And when to do it? That's the job of my friend Ziad in the presentation just after. Is it beneficial? To answer that question, we need a randomized trial. Non-steaming complete revascularization versus revascularization of the culprit artery only. Believe it or not, no such trial does not exist in the literature. It will be available soon. There's a trial called Complete Non-STEMI underway, but for the moment we don't have any randomized data to formally answer this question. When we don't have randomized data, we go to the registries. There are some very fine registries. When we use propensity scores and all the statistical tricks we can to try and avoid confounding factors, we find that complete revascularization of non-STEMI reduces mortality. That's why the guidelines have endorsed this statement and advise us to revascularize non-STEMI patients completely. But you see, the level of evidence is only C, since we don't have any randomized studies. So are there any special cases? For example, cardiogenic shocks or elderly patients. We owe Michel Zetouni a very fine ancillary study of culprit shocks in which he looked at the special case of non-STEMI and looked for an interaction. There was no interaction. If there is no interaction, it means that the treatment effect is homogeneous in all subgroups. In other words, it means that if I have a non-STEMI on the table in cardiogenic shock, I should only treat the culprit lesion. That was the conclusion of culprit shocks. I still have to be able to identify it. Now, the elderly patient is very common. Non-STEMI patients are older than STEMI patients. We are fortunate to have recently received a study called FIRE, which focused on patients over the age of 80 and included both non-STEMI and STEMI patients. At this year's ESC, Gianluca Campo showed us this ancillary study in which he stratified results according to the type of acute coronary syndrome. He shows us that in non-STEMI, the blue curve, complete revascularization, is as beneficial as in STEMI, perhaps even more so. So if I have an elderly non-STEMI subject on the table, it's legitimate to revascularize him completely like a younger subject. then more difficult. On what criteria do I actually make the decision? Do I base it on angiography, on FFR? Maybe FFR derived from angiography, or maybe imaging criteria? Why not? To answer this question, we have a few suggestions. We can look at FREMME. FREMME is a study in which half the participants were non-STEM patients and which compared angiography versus FFR. As you can see from the Kaplan curves, the FFR group did better than the angiography group. In terms of MACE, so it's more in favor of FFR for selecting non-culprit lesions for revascularization in non-STEMI. We'll pass that on. Is there a place for angiography-derived FFR? We have data from the FIRE study, which is that study I was telling you about on elderly patients. In FIRE, it was complete revascularization versus revascularization of the culprit only. But complete revascularization had to be guided by FFR. We had the choice of using FFR with a pressure guide or QFR. We have a number of patients in this study who had QFR, and we were able to evaluate QFR in these non-culprit lesions. We found that firstly, in non-culprit vessels left to medical treatment with lowered QFR, there were many more events. So QFR is associated, abnormal QFR in a non-culpable vessel, it is associated with more events. That's the conclusion we can draw, because we have to be careful. It's a subgroup of subgroups. Attention. Secondly, is there a comparison between angiographic FFR and normal FFR? In the same study, in the intervention arm, we can compare what happened. When doctors made the decision based on QFR or on a pressure guide, there was equivalence. This suggests that both are good tools. Note that this is not a randomized comparison. Again, it's a subgroup of a subgroup. You have to be careful. But overall, we've got some pretty interesting data, and we think it's pretty good. Rather than putting the patient back in, if we've done a good angiogram during the night, the next morning, we'll calmly do the FFR derived from the angiogram on the non-culpable lesion to be able to decide whether to take him back or not, possibly confirming it with a pressure guide. So that's it for the physiological data, but I'd started talking about vulnerability to begin this topo. Now we can finally take an interest, since we're talking about it more and more, and we can appreciate it, particularly through endocoronary imaging. Would this also be a criterion to take into account when selecting non-culpable lesions for revascularization? We have an observational study called PECTUS, and these are patients who had non-culpable lesions that didn't require revascularization, that were FFR negative, but when they were HRP high risk, you see that the risk of having an event on these non-culpable lesions also increases. There's no indication to treat them at the moment. They're FFR negative lesions, but they're vulnerable and they have more events. So perhaps in the future, we'll have to look at these lesions too, and perhaps treat them. We'll see. In conclusion, complete revascularization is recommended in the guidelines. I say appears beneficial because we don't have any randomized trials, so it's hard to be stronger in the conclusion, but the guidelines tell us that it should be done, and even in elderly patients. The FFR, as you've seen, has convincing data to say that it's a good way of guiding revascularization of non-culprit lesions, as Jacques and Mohammed did in the Live in the Box. In this context, there is probably an interest in other tools, such as FFR derived from angiography. Mr. Sarouis also mentioned other types of FFR derived from imaging, and perhaps also take into account plate vulnerability in the future. Thank you very much.
Are there any comments from the panel? Wonderful demonstration by Frederick.
In your practice on NSTEMI multitruncular lesions, do you systematically perform FFR, Johan?
Not really.
Rather not?
Not really.
So you're more of a guide on angio.
We are quite broad in our approach to complete revascularization of NSTEMI, similar to
a bit like the classic STEMI strategy.
We have adopted a simple unisys strategy. STEMI and NSTEMI, same battle.
Jan?
More and more. Physiology, and I think more and more recently with virtual FFR, I think that's it. We'll talk about it later, but it's a happy medium.
Thomas?
On the whole, it's the same thing, but in geographical terms, especially in the older patients you mentioned, it's true that the same reasoning applies as in this morning's pre-TAVI, i.e., when the lesion is intermediate in a comorbid elderly patient, we're going to be more conservative, and sometimes in non-STEMI cases, which we'll talk about later, or in cases of extremely complex vascular approaches, we're going to be wider right away because we have a very complicated patient with 2 fistulas and peripheral bridges. And that's...
So, this week, we're finishing a randomized or multi-trunk study in which we systematically analyze all the vessels by angiographic QFA and give the investigators the answer with the images. They can judge for themselves. They can also do it themselves. They can also do it themselves. We hesitate. You know, between these 75 and 95, the zone of doubt. And what's also important is that we're becoming more and more sensitive to what we call the virtual pullback pressure gradient, because we can see that this FFR curve that's continuously going down without a clear gradient is very difficult to treat. We don't know where to put the stent. And that's something we're vigorously informing investigators about, saying, think twice. This vessel is so diffuse that maybe you're not going to improve things. And it's the same for surgeons by the...
Yes. Yeah.
And Frederick.
QFR for you, are all QFRs the same?
So no, you'd be wrong. They have to be evaluated individually. In fact, it's QFR that has been highlighted in the recommendations, since it has the most solid rationale, with favor 3 China in particular. But all the other manufacturers are coming up with very large trials of the same kind, with 2,000 patients, and especially in the comparator arm and FFR, because favor 3 China was a study against angiography. What we want to do now is test these software programs against FFR, which is the gold standard.
To complete Frederick's question, a practical one, the advent of these virtual FFR techniques will not lead us to perform coronographies under different conditions. In the case of a non-culprit lesion, for example, in the acute phase, we'd have to apply 15 images per second, 2 orthogonal incidences when the lesion is non-culprit. Often we go very, very fast and rush to the acute phase.
We've been talking about it here, and it's probably a good idea because it's the key. If we want to apply, if we want to draw the most accurate conclusions possible from this type of solution, it's the image and the 3D reconstruction that form the basis of the mathematical model. So if you don't have good imaging, you can't draw conclusions from this software. That's why we're increasingly adopting the reflex of filming them carefully when we anticipate the idea we're taking.
We have to tell the audience that the European Society of Cardiology guidelines have introduced QFR at 1B. Okay, 1B because there isn't one. There is only one large randomized study. But what we're looking for example, from Pioneer 4, which randomizes this principle, is confirmation. So 1A could become 1B, could become 1A. And I think the other software, as you call it, are waiting for clinical data to be recognized by the guideline people.
Frederick, I have a question about microcirculation. Jacques' FFR is unequivocal, but as we've seen, it's an enormous diagonal which has almost a territory. There's necrosis in this territory. What value do you think the FFR has in the VIA territory, which in the end is a territory that has quite a lot in common with this diagonal, which is infarcted? Do you think this FFR is a reliable, reproducible measurement? And if it were unequivocal, what would you do with this result?
It's a tiny bit technical, but when you're going to physiologically interrogate a non-culprit lesion, and when there's been significant necrosis, in fact, in the acute phase and in the first few days, there is an impact, a small impact, on the physiological assessment of non-culprit lesions. Jean, why is this? Because when there's a really big necrosis in the non-infarcted territories, there are 2 things. Compensatory hyperkinesia, which slightly increases the resting flow, and there's still a bit of edema, which, when hyperemia is applied, reduces maximum flow a little. Consequently, if you do FFR, an index based on hyperemia, in the very acute phase, the figure will be slightly overestimated. For example, if you find FFR in the overacute phase in the first few days, 6 weeks later, you may find 0, 4, 22. The difference is of the order of 0.2, 0.3. Conversely, if you use a resting index, it's the other way around. In other words, if you use the IFR, for example, in the acute phase, it's a very small difference, underestimated compared to the value you'll find later on. It's not a big deal. It's not a big deal because, as Professor Serruy said, what counts in 2024 is not so much the number as the profile. Is it diffuse or focal? I don't think that 0.81 or 0.79 are very different. What counts is whether it's focal or diffuse.
All right, thank you very much. That's very clear. And now we're going to get into the technical side of things since we've set the indication. So Jacques, how did you treat this calcified lesion?
So we've just brought in a 3.0 shockwave ball, which is virtually occlusive, without the need to predilate. We're go and deliver our first sequence. That's it. I'm at 4 atmospheres. Small footprint. We're at the end of the shooting sequence. We've already done 110. And we're finishing on the proximal lesion, which is perhaps a little more resistant than the distal lesion. So we're at 14 atmospheres with a 3.0 by 26 millimeter balloon. So we do a second round of AVUS after the shockwave preparation plus the uncomplicated ball, Mohammed.
So now we'll rely on the 1, 2, 3 rule. We'll measure the length. We're going to measure the diameter in the healthy zone on the proximal distal part. We have a long length, 40 millimeters, a distal diameter at 2.5. Here we see a live uncomplicated dissection of the middle anterior interventricular on fibrocalcific lesions, as seen previously. We go back to our areas of interest, which were calcareous arches between 270 and circumferential. We're going to have a rather interesting zone of interest. We can pause here. Now we have a calcified lesion, this time with fracture lines. An expansion is obtained since previously we had 2 square millimeters. Now we're between 3 times 70 and 4. So we have our criteria for the effectiveness of our active balloon angioplasty. Shockwave, forgive me. We go up the proximal to middle IVA just downstream of the first diagonal with an atheromatous lesion. We've done a bit of serum flush and are now approaching the anterior interventricular bifurcation. First diagonal with a tight calcified stenosis with a lumen that we'll measure here by pausing. An artery which at the level of the proximal anterior interventricular at the diagonal bifurcation is 4.5. Our strategy, based on the measurements we've taken, is to insert a first stent whose diameter is adapted to the distal part of 2.5 millimeters, the length 40 millimeters to reach the septal, and then a complement with a 3.5 stent, which will reach the ostium of the IVA and make it a pot, I think, around 4.5.
On the technical aspects, does the panel have any comment? Simply, before giving the floor to Thomas, you often don't dilate very much when you're doing shockwave.
I try to bring the ball along unless the injury is really too critical. It didn't seem that critical to me, so I tried. With this patient who was still fragile, I still wanted to go as fast as possible. The Lieb was turning. Anyway, it
was just a little comment on sizing and imaging. There's always the idea, should we take the lumen, the external elastic limit, or should we take the lumen? And I find that on these very atheromatous arteries with an important charge of atheroma, considering to expand the stent up to the external elastic limit, I don't know, I'd like to have Pascal's opinion. But it's true that I generally take the lumen and add a little more to it, rather than saying I'm going to make all the atheroma disappear and my stent will be able to go everywhere. Everywhere. Personally,
do the same.
I completely agree. all the more so as the external elastic boundary is delimited on arteries that are petrified, sometimes even with off-center calcareous buds. You can see very, very clearly the ruptures that occur in the connection zones between the horn of the healthy zone and the calcification. I find it very, very difficult to rely on imaging to make a decision.
We're at 2/8 of light, we're at 4/5 of external elastic limit. I probably wouldn't go for 4/5.
Since Mohammed was mentioned, we can also see that there is a subplate hematoma which modifies and biases the measurements.
The quality of the eye views is noteworthy. The images are very pretty. The shadow cones and calcified plaques are clearly visible, so it's very interesting. So here we are with complete revascularization. We've all endorsed it. We're going to ask Ziad Bouri if, in his practice and in the literature, there are any points of reflection that would enable us to say that it should be done during hospitalization or a little later.
Thank you. Thank you for what, Jacques. You chose to do it during hospitalization, but with a staggered procedure. So I have no conflict of interest with this presentation, and so I'm going to try to talk to you a little about what the ideal timing is in non-STEMI, where we have very little data. First of all, the hardest thing is to identify the culprit lesion, and we know that this is not always easy. The second difficulty comes from the assessment aspect we touched on earlier, which is also correlated with whether or not they should be treated, as we can end up with tritruncular lesions that are not. And then the real question, in fact, there are three scenarios. The first is complete revascularization, as was done during the studies, of all the lesions in the single initial procedure. The second, during the same hospitalization, and the third scenario is what we did for a long time in a second hospitalization. So what data do we really have at present? This was just to illustrate that sometimes it's not easy. This is a 78-year-old patient with tritruncular lesions. This patient was treated since it was an acceptable time. He didn't want to undergo surgery, so he benefited from complete revascularization. Thanks to Frederick for showing us this slide where you can really see that there are very few patients in randomized non-STEMI trials. I tried to look at the timing of the randomized studies. When you see it, it's often the same stay, so there for SMILE you're at 5-6 days, at 48 hours for FIRE. The only study in which they did it at a distance was BioVasc, where it had to be done within 6 weeks and during the same hospital stay for FRAME-MI. So the guidelines, as you can see, are really, we have a green light for STEMI. We can do it even during the same procedure at a distance up to 45 days. And for non-STEMI, we really have recommendations that are very timid. 2 A's with a functional evaluation that's not entirely obvious. That's just to show you the 3 studies on which they base themselves. SMILE, which was the first in 2016, i.e. a procedure during the same stay, 4-5 days, is an old study between 2011 and 2013 with 17% of active STEMIs. So we're no longer bare stents, sorry, but it's a study that could have answered. There are 2 centers, but there it is. It's a study that opened the way, and it's all non-STEMIs. The meta-analysis goes a little in the same direction, saying that we can revascularize patients with non-STEMI by Sivert, but when the patients are suitable, in fact, the studies come after the guidelines. They are very interesting. I'm going to go very quickly. We've already talked about it. FIRE with complete revascularization at 48 hours, positive results, and we have an introduction of QFR and FFR. BioVasc, as you can see here, is less than 6 weeks, and we can see that the results are not statistically significant, but we can see that there are fewer events in complete revascularization. FRAME-MI is more or less the same thing, but we also evaluate the physiology beforehand, and as you know, we have the French paradox. We no longer have FFR. Here's Hakim's word. We've got a big problem. We've seen a fall in the FFR. That's not the point. but I'm trying to get you to think about it. Indeed, virtual FFR can replace it with great care, but there's also the concept of the unstable plaque and what Frederick was saying earlier. And so we have several means at the scanner with FAI, OCT, and in angiography now we have some tools. I think that those who attended the session just before this paper, which is very interesting, by Fezzi, which was published last year in the European Heart, which talks about this radial wall strain, which is also artificial intelligence. Here's a patient who was treated on the circumflex on a non-STEMI and who had a negative FFR on the right coronary, or a rather negative QFR. And this patient came back a year later with a plaque rupture, in fact an infarction on the right coronary. And so they reviewed his image from a year ago, and in fact Brahim talked earlier about this interesting tool which is RDWS, and in fact when you combine the two, the physiology and the vulnerability of plaques, it can be something interesting. There are studies that have looked at this, so there's Favor China 3. When you look on the left, you have patients who have micro FRs that are negative over 0.420. These patients, when they have high RWS, they have more cardiovascular events. So these are things maybe potentially in the future that can guide us. You see, this is a patient, so I thank Pulse Medical for helping us with the realization. It hasn't been commercialized yet. A patient we did last week with a micro FR at 0.65 that we would have treated but without urgency. And when you look at the RWS of this patient, well, it's very high. At 34%, shouldn't he be treated before discharge? These are really questions. So in fact, to try and summarize, there's full rehabilitation during the same procedure. I'm not a great believer in it, but it depends on the complexity of the lesion. We don't do a staff procedure. We go and staff the patient ourselves. And if we don't know the patient well, that's important. You can't treat a patient at 3 o'clock in the morning with a very complicated, complete revascularization. So I think that's a factor to be taken into account by the operator. So to sum up, for me it's clinical common sense, and this common sense I found in this paper by Sanchez in Heart. It's really very well done. So lesions, severe non-culprites can be done in a simple strategy, simple procedure, when there's no real hemodynamic instability, and when they need to be shifted, when the patient is delicate, when it's a complex procedure. I think it's really common sense. We're missing this study. I think it's called the missing trial. It's to maybe randomize with 3 immediate arms during hospitalization. And I think that after discharge, in a second phase, we might have some answers. So in fact, in summary, base it on physiological assessment. It all depends on the procedure, and of course there's the clinical sense, the anatomical conditions of the patient. A second procedure is quite conceivable with common sense on critical lesions during hospitalization, or even remotely if the patient is not worrying and maybe there are places for artificial intelligence. Thank you, Ziad.
Thank you very much, Ziad. Actually, it goes back to what Johan said at the beginning of the session. It's very heterogeneous. Yes, it's hard to find your way around because it's a very broad group. In your practice, if we were to give you some simple ideas, Jacques' patient, you would have revascularized him during the same hospitalization. Or would you have discharged him, and in which case? How long would it have taken?
I think I would have joined Jacques because he's already a fragile patient. You've seen that he has severe LV damage. And I wouldn't have done it in the same procedure because you really have to prepare the patient, and the patient wasn't necessarily very stable, but there are plenty of patients who can be revascularized if they have stable lesions, I think, and critical in the same procedure. So it's really common sense. And it depends on each patient and their anatomy.
Thomas, what would you do in Marseille?
In non-STEMI, we're going to say all coming, it's very staged, i.e. In 2 times, it's exceptional to do everything at once. So it's rather non-STEMI than non-STEMI and in the same hospitalization.
STEMI.
For example, in the case of a patient who was due to have a gastrointestinal checkup, and it's clear that there's a risk of ending up with a little bit of metal in the IVA, perhaps I would have taken the time to do the gastrointestinal checkup, to get to know the patient better, to be sure that he's not due to have colon cancer surgery in the next few weeks before putting 50 millimeters of stent in the IVA. So by default, it's a 2-stage procedure carried out in the same hospital, but sometimes, depending on the patient's complexity, it can be deferred in certain cases.
That sounds very wise. Let's get on with the LIAB. Find out how I got a question. Once again, Patrick.
Yes, I think what's going to be a destabilizing factor for all of us is the fact that you have this debate between physiology and the vulnerable plate. It's a debate difficult, and I'm amazed to see that non-invasive imaging is progressing faster than the physiology debate. It's amazing that the latest recommendations for non-invasive imaging that you can do in non-STEMI multivessel, we have time to do a multi-slide CT scan. Finally, there are 5 parameters that play a role in delta FFR CT: total atheroma volume attenuation, and finally flow, which is becoming possible with multi-slide CT scans. I think that in the years to come, we're going to be destabilized by imaging that has already bridged the gap between the vulnerable and the physiological, which we haven't done with intravascular imaging. This is very important. And then photo counting is a revelation, truly exceptional. I've just come back from 3 days in Sevilla for the Vulnerable Plaque Conference. The images we've seen are extraordinary. It's very similar to intravascular IVUS. So it's going to be a rapid evolution in that direction, mixing physiology and vulnerable plaque. You can't separate, you can't dichotomize this problem.
Thank you for that. And we'll move on to the last part of the LIAB, please. We opt for a Supreme HT 2-point stent, 5 by 35 millimeters. And then, as Mohammed said, we'll put a 3.5 above it. So the stent descends perfectly well. We're going to do a little test to position it. Pull a little bit. It's not bad. We'll do a little test. We're fine. How does it feel? And so I'm going to inflate to 14 atmospheres. We'll be at 2.7. So we think the geographic result is very satisfactory, perhaps a little under-deployed in the proximal part. And we'll use a non-compliant balloon 3.0 to perfect the result. Here we'll place the 3.5 by 30 millimeters on the proximal and middle IVA, covering the diagonal. We're just a little overlap of about a good millimeter. And up there, I think, we're perfectly positioned. We're fine. And we decided to make a pot on the proximal winter upstream of the birth of the diagonal with a 4.5 by 6 millimeters. You position yourself well on the hull. I'm at 12, 14 with the 4.5 by 6. You see on the clear stent, we're going to pull a little bit to position the first mesh of the stent. And Mohammed and I came up with the idea of kissing. Here we're kissing with our 2 balloons. 2.5s and 3.5s, 14 atmospheres. We're going to finish the procedure by making a final pot with our 4.5 by 6 millimeters.
We've just performed the end of procedure IVUS. We can see that the stent is perfectly opposed distally. We've made reference measurements and can see that expansion exceeds 100% because the stent was then overexpanded. Here's our first stent, which covers the lesions perfectly with no malapposition, no bank dissection, and expansion of 100%. No eccentricity, no elliptical deformation of this stent in the middle anterior interventricular artery. We're now going to approach the junction of the two stents shown here with a 3.5 stent this time, which likewise shows no apposition defect, perfect expansion, no eccentricity, and we're going to arrive at the bifurcation of the IVA and the diagonal we've just crossed. So we're very happy, very satisfied with the geographical result. No dissection either distally or distally, and perfect expansion.
Very good, Mohammed. We still have to do
an FFR of
a control FFR. You remember we had 0.111 basal. We're at 0.92 basal. And so we're going to finish with a real FFR. All these factors are in complete agreement on an excellent result, both geographically. We'll show you a final angiophile, especially with the EVIOS criteria described by Mohammed. And so we do the FFR, and we have 0.88 of FFR in this distal AV. The final result. Listen, for us, the final result is superb. And so we end this case of multitruncular lesion in a patient who had undergone NSTEMI a little over 10 days ago, with lesions on the middle IVA that were tight and calcified, which we prepared for shockwave, and then a lesion on the proximal IVA opposite the diagonal, which we treated classically, i.e. with 2 active stents, HT Supreme, a mesh reopening with kissing, a pot, then a final pot.
Jacques, can you give us the evolution?
If I can just have my last slide, please.
Patient.
Right, so the aftermath was straightforward. The patient was discharged 48 hours later and on antiaggregant therapy. You'll recall he was on ticagrelor or aspirin. I decided to leave him on this combination for a month and then de-escalate, replacing the ticagrelor with Plavix. I started out with a 1-year plan, and I think I'll adjust it to take account of the patient's fragile condition when I see him again at the beginning of October.
Nevertheless, Thomas, high ischemic risk, high hemorrhagic risk. What do we do about this de-escalation? Thank you very much, Jacques. You have to be as careful as with mountains. De-escalation is where you break your face.
So exactly, for a 6 o'clock topo on antiplastics, I promise you we'll keep it simple. There will be very few complicated things, maybe none at all. No, the idea is to be really practical. So I've started from another clinical case, but basically it's the same thing. It's just a slightly younger man with a non-STEMI and trying to discuss it. In the end, it was the antiplatelets. There are 3 important moments. The moment before, which I'm going to go over very quickly, the moment during, and we'll talk mainly about the moment after. So the first moment is what we do before taking the patient to the catheterization room. My friend Johan did this very well. I won't go into that again. Indeed, there were several options on the table for the upstream strategy, i.e. before going to the coronary angiography room. And as Johan said, today we don't give P2Y12 blockers, we only give aspirin. Obviously, only if you have an early invasive strategy. If for logistical or organizational reasons, the coronary angiography is going to be in 3 or 4 days' time, then we might consider giving a second antiplatelet agent. Otherwise, we'll just give aspirin. So what's the philosophy behind all this? Johan made it quite clear. It's like we said in non-STEMI in general, we're not sure of the diagnosis, we're not sure if there's thrombus, we're not sure we're going to dilate because even in a COST, troponin plus, so really well-selected patients, in the end we end up with a big half of angioplasty. This means that we'll be pre-treating a lot of patients with myocarditis, Takotsubo, and other conditions. So obviously, if it's beneficial in half the patients, it probably doesn't make sense. And on the other hand, even if it's been rediscussed in the guidelines, and we can discuss it for a long time, personally, I don't necessarily agree with rediscussing it, because with STEMI it's different. We're sure of what's going on, we're sure of what's going on. We're sure there's a clot, because it's marked on the electrocardiogram that the artery is blocked, and we're pretty sure we're going to do a primary angioplasty. So, in the end, the three arguments that led us not to do anything before in the non-STEMI condition, no doubt lead us to do it systematically in the STEMI condition. So here we have a patient who goes to the OR, who's only had aspirin, and here it's a little simpler. Here it's a little simpler because it was monotruncular. So here, in the same way, we have a patient on the table, same thing for Jacques' patient. So what are we going to give? So in fact, in a younger patient, but even in a patient of Jacques' age, we'll try to give fairly powerful P2Y12 blockers in the non-STEMI setting, because on the one hand, it'll work better, but above all, it'll work faster, i.e. 45 to 1 hour after giving him the drugs, it'll be effective. And we know that in a post-angioplasty context, in a non-STEMI setting, you want to be effective quickly. There are also very simple messages about what to do at the time of angioplasty in non-STEMI. So first of all, as we've said, we've only had aspirin before, so we're going to give a loading dose of P2Y12 as soon as angioplasty is considered. Secondly, we will give preference to powerful P2Y12 blockers, i.e. prasugrel, ticagrelor, and we will reserve P2Y12 for the other two. And the important thing is to choose between the two. Johan mentioned ISA-REAC V, which compared the two, which is what was validated in the guidelines, but I would say that beyond the obvious, there are other arguments for preferring prasugrel, in my opinion. It's a monoprice, it's generic, and that can be important. There's a lot of talk about budgets at the moment, so I think that can be important. And then tolerance, i.e. apart from the bleeding risk associated with the antiplatelet agent, there are no exotic side effects. In my opinion, clopidogrel in non-STEMI in the early phase should really be reserved for patients at high risk of bleeding. Injectable antiplatelet drugs to complement oral bitherapy. It will be given in very specific cases. Overall, high thrombotic load, complications during angioplasty. And finally, we said before not much, to be very efficient at the time of angioplasty. And now we've just talked to Jacques' patient about discharge. So what can we retain as a recipe for non-STEMI exit treatment? We can talk about angioplasty, but that's not the principle. So in the end, there are plenty of options here too. Lots of options in terms of combination, lots of options in terms of duration. To try and keep things simple, we already have the non-STEAM patient we've just seen. Here, the young patient at very high ischemic risk, at low hemorrhagic risk. In this case, we're going to give him powerful drugs, and we're generally going to give them for a long time. We often go beyond 1 year with dual antiplatelet therapy. At the other end of the spectrum, at a much more caricatured end of the spectrum, we have patients at very high risk of bleeding. The caricature is obviously the patient on anticoagulant therapy, but it could also be the elderly patient or the patient with comorbidities. In this case, we're going to reduce the dose, i.e. we're going to use less force and for shorter periods. We'll give them clopidogrel, and we'll generally use short dual therapies. And in these patients, known as HBRs, high risk of bleeding, the choice of the right stent that has demonstrated a benefit in this population, notably in the literature, will be extremely important. And finally, there is also a middle way. In the end, it's Jacques' patient. On the one hand, this patient is at high risk of ischemia because he is non-STEMI, has a poor LV, and is multivessel. But on the other hand, he's elderly and has digestive problems, so he's also at high risk of bleeding. So in these patients who are a bit in between, we can indeed propose, and this is what Jacques proposed, I didn't know, but de-escalation strategies. Immediately after the acute accident, will be optimal. We'll give aspirin and prasugrel or aspirin. And generally, between a week and a month later, we'll reduce the dosage to find a compromise between ischemic and hemorrhagic risk. So the idea is aspirin, prasugrel for a month, and then aspirin. Clopidogrel. A whole host of studies have been carried out. And another de-escalation strategy is the possibility of stopping aspirin, as proposed in the Twilight TICO studies, and this time keeping ticagrelor on its own. So finally, the question we have to ask ourselves is this. We've said from the outset that this is an extremely heterogeneous group. So it's true for revascularization strategy, timing, what we do with non-culpable lesions, and it's the same for antiplatelet agents. So we have to try and situate our patient between ischemic risk and hemorrhagic risk. And finally, as we said, we'll look at the risk of bleeding and the risk of ischemia. A little bit of what we do with our hands and with our stents, but I don't think that's the main criterion for choosing an antiplatelet strategy today. And finally, if he's rather young, he'll clearly be on the high-risk ischemic side. So we'll use strong dual therapy and prolonged dual therapy. An important message is what we put on our reports. So he'll probably be discharged with aspirin and prasugrel for at least a year. An important message is that our antiplatelet strategies are dynamic. It's not set in stone. If it comes out on the 12th of March, it doesn't have to be until the 12th of March next year to take exactly what we've planned. Because we're going to follow it, there are bound to be tolerance problems, there are bound to be new events, and we're generally going to move from an a priori antiplastic strategy on release to a final antiplastic strategy, and we know that at least one time out of 3, the final strategy won't be the a priori strategy. So to keep things very simple, for the antiplatelet strategy in non-STEMI patients before his aspirin, while it is a strong P2Y12 blocker, except really in patients at high risk of bleeding and injectable antiplastics, it's really in very selected cases. And for the rest, i.e. after discharge, there are a whole host of recipes in terms of combination and duration. And I think we need to make the effort to individualize for each patient. And we can do very strong, very weak, or these intermediate strategies that respond quite well to ischemia hemorrhage trade-offs. Thank you very much.
Thank you very much, Thomas. Panel, I'd like to make 1 or 2 comments before concluding this session. Mr. Saruiz? No. Well, listen, I think we should thank everyone for this superb session, which highlighted the fact that these acute coronary syndromes and ST- are, when it comes to an extremely heterogeneous and complex pathology, navigating between the hemorrhagic risk and the ischemic risk. I think we've seen that to find the middle way. I really liked your middle way. Siddhartha sitting at the foot of a tree, father of Buddhism. Well, to find that middle path, you need to master several techniques, hemodynamics and imaging. And thank you very much, Jacques, for building this session. Thank you to all our speakers.